Welcome to Joint Effort PAs, where two orthopedic surgery PAs get real about life in medicine. From tips and tricks to professional growth, work-life balance, and everything in between. We're here to share what we've learned and what we're still figuring out. Let's get into it.
All right.
Okay, let's do it. Let's talk about the elbow.
We're shifting gears this week. We're getting right back on track.
Yes. Some clinically relevant topics, but very well timed. Clinically relevant topics.
Yes. Yeah. Today we're going to talk about the elbow, which I think is a scary joint for a lot of people.
It is. Yeah.
You know?
I feel like the elbow is really difficult. Like you think it's simple initially.
Right.
And it's so not simple.
Yeah. Even the shoulder too. I think shoulder's like runner up.
Yeah. Because you're like, oh, this is like, this joint does this. And there's like these three things that it could possibly be that they teach you about in school. But then there's so many more.
Yeah. There's like 20 other things that it could be that you don't even know are clinical entities until you get into orthopedics.
Yeah. Well, preface, describe your week, Beth.
Oh my God. This week was insane. The week started Monday. No, the week started Saturday when I SOS texted Hannah and I was like, hey, I think my husband tore his biceps and you need to put him on the surgery schedule this week. She's like, oh, great. Can I see him? I'm like, no, he's away. He's away and he doesn't get home till Monday night. If he gets home, because there's a massive forest fire where he is, whatever. But anyway, yeah. So he tore his bicep. He had surgery Tuesday. I maybe worked the entire day.
Yes.
On Tuesday because it was so unplanned. But yeah, that, I don't know. It's always weird when you have like, this is what you do every day.
Yeah.
And then it like enters your home. You know what I mean?
Do you feel like it makes you more empathetic, more empathetic towards the process? Or do you feel like so detached? Like I almost feel like, I don't know, if my dad tore his biceps and had surgery, I'd be like, this is just like a regular day for me. Like,
yeah, no, it felt very regular.
Not for them.
No, it felt regular for me. And to give him credit, he also made it seem very regular. Like he seemed very okay with the fact that I like orchestrated, like, I need you to do this. I need you. Like there was no conversation. In fact, when your surgeon talked to him beforehand, I was like, oh yeah, so we'll be down for 8 weeks. And he was like, I'm sorry, 8 weeks? Like, I mean, we didn't talk about that because I was very much in like planning mode.
Yeah.
So I don't know that he got all of the preoperative info. I've been like slowly giving it to him.
Well, that's obviously the last piece of information you give because it's the hardest to swallow. So.
It is. But I mean, again, logistically, right?
Yeah.
So day of, you're like, hey, like, do you have a pharmacy? I'll send the meds. So when I had you send the meds, I didn't have time to get them. Like I didn't get them because the day was what it was.
You were still working.
It was still working. So like after we finished our surgery day, I like went, got meds and came home and oh my God, but anyway, that was just part of the week.
Yeah.
And then, the week itself went okay. I did a cadaver lab on
that same day,
that
right?
same day.
Yeah.
Oh my God. Yeah. That was that morning of, and I tried to coordinate. I think I did. I coordinated everything to like get everything done and also get him to and from whatever. So we did a cadaver lab and that was on an arthroscopic, Lateral type procedure. So I think we'll be able to do that, but it goes back to putting the shoulder in lateral to cubitus, which I hadn't done in like 10 years. So that'll be annoying, but I think we can do that. We've done these open, but now this is a good way to do it arthroscopically.
This is getting off topic. What like are you using for graft for that?
It would still be the distal tib allograft. Yeah.
Okay.
So you can use the coracoid, but we won't. We use like a distal tib, which we have to match and do the whole thing. But normally it's like big open incision, detached subscap, and the visualization is just so poor, to be honest.
I think of this like the hemihamate procedure that we did.
Yeah.
No. But we basically take a piece of the hamate and match that to fit the contour of like
that's exactly it.
Fixable fracture.
So you take the distal tib and you match the contour of the anterior glenoid.
Yeah,
it fits pretty well. Yeah, it fits pretty well. So it's all, and there's no screws. It's all like a tightrope suture fixation, which is kind of crazy.
And that's for recurrent
anterior instability with more than 20% glenoid bone loss. So we have patients that we could do this for. But anyway, so that was cadaver lab. Then it was our surgery day. That was my husband's surgery day. But like when things go not planned like that, I mean, I was telling you, I went home this weekend with like 76 open notes, which is, I told you once upon a time, my number of like concern is 12.
Yeah. So you like literally,
I just like, I couldn't catch up because I would come home and then he can't like do anything with his left arm. So like I'm making dinner and I'm trying to do all the things. So I didn't have time to do the things I would normally do. Plus my daughter's birthday was this week. I went down, drove 2 hours to go with my son who was with my parents.
It was 4th of July.
It was 4th of July.
Your dad just had surgery.
I interviewed 2 medical assistants this week. I interviewed a couple PAs. Like there was just a lot of things. I did some training this week with another PA. So, I mean, the saddest part though is that Friday was yet another non-surgery day.
I know. I missed it. Yeah.
I did.
And I like, to me, it was silly. I was like, wait, why are we off Friday? I mean, like, whatever. I get it. This is America's 250th birthday. Like, I'm not saying we shouldn't celebrate it, but like the 4th was on a Saturday. Could we have worked Friday? I think we could have.
It's the observed holiday.
But not everybody observed it. So I don't know. This is just me being a crazy person.
Yeah. Well, I wouldn't have minded if it was a Monday. Is that weird?
No, I think Monday would have been better.
Better.
Actually, it would have been the same for me because those are both full clinic days for me. So it would have affected me the same, I guess.
Yeah.
I feel like it's hard though when a Monday is off because Tuesday is an OR day and jumping like without any of the prep from nothing to OR day is, I don't like it.
Yeah. That too for us when we're off Monday and then Tuesday, like nobody, there's no prep for Tuesday because you just dive into that. It's a little bit weird.
Something always like goes awry.
Yeah.
Yeah, that was interesting Tuesday. Beth was literally like, dressed out, like seeing probably your patients and pre-op and pack you and then going into your husband's and be like, hey.
Well, you know what's funny though?
Next door.
You know what's funny, not funny, is that your surgeon was like, hey, once I get like all prepped, do you want to come in and like watch? And knee jerk, I was like, no. But
then in retrospect, you were like,
I know. But my I don't know, my family part of me was like, no, why would I do that? Like, I don't know. And then part of me afterwards was like, why did I say no? That was weird. Because I just sat like,
sat outside the door.
I sat outside. No, I didn't sit outside the door. I just sat like, I don't know, waiting. I was like, okay, they must have tourniquet up. Okay, like, they must be making a incision. Okay, if they're struggling now. Like, that's what I was thinking instead. But I didn't want to put pressure of like the lean. Like, nobody needs that.
Yeah, nobody needs that. Like, if Beth had come in to watch me close or something, I would have like fucking died.
No, so I said no, and I thought that was the right thing to do. But I appreciate all the pictures afterwards. That was literally the best part. But yeah, so that was that. And then the cases for the week, even though we lost the whole surgery day, they were good. And then clinic was good. And then again, all the other stuff that happened. But I feel a different level of tired this weekend than I did last weekend. Yeah. What about you? How was your week?
Oh, it was something. I mean, Tuesday was the best day of all.
Yeah.
Because we got to fix the elbow.
I know. And I actually know, but back up Monday. Remember we had him come in and he rolled up his sleeve and all he did was supinate his forearm. We were both like, oh my God.
It was just so like crazy. It was, everybody looked at it at first glance. Was like, whoa.
I know it was. I mean, those injuries.
Do you remember who else has a shocking bicep like that?
Oh yes, I do. Yeah, but that's the thing. I don't want him to live.
You're
with
like,
that.
I don't want you to fucking look like that.
No, I know someone. I know someone who never got that fixed. It's terrible.
I can't live looking at that every day.
I can't live looking at that. That's
too weird.
Deal breaker. But it did spawn our topic this week of elbow.
It was helpful. So I'll give it that. Yeah. But other than that, we had a good surgery week. It was kind of lighter week because we missed out again on Friday. So those weeks I'm always like, I feel like I'm negative because everybody's like working hard and ready for the long weekend and like excited. And I'm like, guys, we suck this week.
No,
just
I know.
So you know, we're like, we're terrible.
It's not the feeling of like sucking. It's the feeling of like what could have been.
Yeah.
This
could have been.
This could have been. But I'm at the point now in my career, like I know in holiday weekends what bad things are going to happen. So on Thursday, which was our last day, we had our team meeting. I was like, all right, we have one patient on a wound vac this weekend. So I need someone to be like around and on call. And they were like, what are you talking about? Like, we just saw him yesterday. I'm like, I know, but
it's
going to be something. So lo and behold, yesterday I got a picture. Hey, the guy with the wound vac, he took a shower. He thinks some water got into it. So he removed the whole thing.
Oh God.
Now our urgent care is open till 4 yesterday. This was at 3:37.
Oh my God.
Which means no one is there to help him. So then I get a picture of the open wound that he decided to just expose something and said, oh, hey, he put a Band-Aid on it. Any other instructions?
You're like, at this point, no.
No. So I had one of the providers who was leaving one facility and driving by the second. She came to the second one to meet him because all of his stuff was here. And I said,
nice.
maybe we
Yeah.
should,
Yeah.
we should take some of his stuff to the other location just in case. And everyone's like, no. And guess what? We could have used it.
Would
Anyway.
have worked out well. Oh my gosh.
It's just, it's like without fail. That
But you
just
also
always,
know that,
always
like,
happens.
because of these 3 days, that next week is going to be like
it's going to be
chaotic
crazy.
because of it.
Did you look ahead and see like?
Yeah, we're scheduled for 196 patients collectively this week. My team specifically.
What is normal?
I mean, I had some weeks where I was over 100 myself. So for reference, last week on our, not busy week, it was like 130 or something because we missed a whole big day of clinic. But usually like I would say 150, high 150s to like 170 or something is normal. So 196 is like verging on super busy, which is great. And I'm certain that somebody broke their wrist or a finger this weekend or something.
Oh, somebody did. Yeah.
And I will catch wind of it tomorrow, possibly.
You definitely will.
So it'll be good. Next week will be a great week.
Good.
So the elbow. The elbow can be the bane of our existence.
Why do you think it's so scary for some people?
Because it's a weird looking joint. Like if you just like looked at a picture of an elbow, it's like, what is all this?
Yeah. like why? I think though also if you have been doing this long enough, pediatric elbows.
Oh,
those are.
I won't even get into that. That's a whole separate friggin' thing.
Yeah.
My word of advice with pediatric elbows is just be cautious with everything.
You have to.
Yeah. Just everything's something.
Everything is something.
Yeah.
Yeah. So yeah, let's dive into it. So when you look at the elbow, I think it's concerning because it's 3 bones making up a joint.
Yeah.
I mean, it's not 2, right?
Yeah.
I mean, the kneecap's 3. I'm sorry, the knee joint's 3 if you count the kneecap, but like, come on.
But like, what?
Come on.
What is the kneecap?
What is the kneecap? I think it's just it adds that extra element. And when you add planes of motion, like again, the shoulder's scary because there's so many planes of motion, and then there's compound movements like abduction, external rotation. With the elbow too, like you've got flexion, extension, but what the hell is this pronation, supination?
Yeah. And where's that coming from?
Where's that coming from? You got to account for all the forces that allow for, the range of motion, the planes of motion.
Yeah. You can think of it very simply, but you can, if you get into the weeds, you can really get into the weeds. So stepwise approach to elbow pain. I guess the easiest way initially when you're looking at things is pain location. Like where is this coming from and what are the most likely? This is how you really should think about most things. What are the most likely causes based on where they're hurting?
Yes.
So starting with lateral elbow pain, our good old tennis elbow, the cancer, a cancer of our lives.
The cancer, but I'll tell you what, not all lateral pain is tennis elbow. And I think it's very common for new providers to just group all lateral elbow pain into tennis elbow.
Because it's a safety diagnosis, right?
It is.
I feel like from an urgent care perspective, like nobody's really going to fault you if somebody comes in with lateral elbow pain and you diagnose them and initially start treating them as tennis elbow and it turns out to be something a little bit more intricate. Like you're not going to be labeled as like an idiot, I don't think.
Yeah, no, I don't think so either. Because I think also you can start with that as a diagnosis, treat it accordingly, because if it is or if it isn't, if you do immobilization, injections, anti-inflammatory therapy, most things likely get better from that. So I don't think you're making a huge misdiagnosis, but I think if you want to be an expert of the elbow, you've got to really tease out like what are the other things that live there and what are the other things that can cause pain.
Yeah. So we also have radial tunnel syndrome to consider, which is like the stepchild to tennis elbow.
Yeah.
I only say that because it can coexist.
Yeah. They go together a lot, but not often enough where you say that they always go together. But I think lateral epicondylitis is radial tunnel syndrome is sometimes grouped into lateral epicondylitis. And then once you go through this step treatment for lateral epicondylitis, then I think maybe on visit 2 or 3, you're like, that seems like it's more the nerve. It's a little bit more distal than I thought it was going to be.
A little bit, some extra symptoms, right? Your classic tennis elbow, lateral elbow pain over the ECRB insertion, positive grip test. So if they like squeeze and make a tight fist with their elbow extended, that typically hurts. Pain with resisted wrist extension, because it's actually more pathology coming from like your wrist-informed extensors rather than like a
Elbow
pain that
range
somebody feels
motion.
when your elbow moves. Versus radial tunnel syndrome, you're going to look more at like more of a dorsal radial forearm pain. It can be kind of vague. They usually have point tenderness a little bit more distal. Sometimes a positive Tinel sign over the nerve, pain that radiates into their dorsal hands, sometimes paresthesias with it.
It's not going to be textbook like radial nerve issue, wrist drop. It's not going to be that.
Yeah.
I do think the difference between the tennis elbow and the radial tunnel syndrome is how vague the radial tunnel syndrome symptoms are. We do a lot of radial tunnel nerve blocks that we will send to you guys if positive. So when we do those, I actually I've done them both in the form like distally, but I've also done them proximal to the elbow. And again, a positive test would be if the patient's symptoms decrease for a very short period of time, aka lidocaine time, then that's usually radial tunnel syndrome. Now, EMG, if you're worried about radial tunnel syndrome, do you get an EMG on these people?
Sometimes, very rarely. If there's like motor weakness issues, probably, but usually not, because an EMG isn't great at picking it up. It is not great.
Like, it is very inconclusive. So communicating with a patient what you think the diagnosis is, and then working through like, I need an MRI, like not for radial tunnel. I need an EMG. Well, guess what? It may come back normal. So I like the diagnostic nerve block as the test of choice.
Yeah. Because then you can actually just saw a patient of y'all's this week who had a positive diagnostic block. And radial tunnel is like so hard to definitively diagnose from imaging. So I always have the conversation like, hey, this is something I can't really like see on an MRI, not always see it on an EMG, but you responded positively to a block in that location. So theoretically, by treating this, by doing the release, you should get better. Now,
what if they don't?
What if you don't? I mean, I don't know. We'll cross that bridge when we come to it, but you should.
But diagnosis of exclusion, meaning you've treated them for lateral epicondylitis. MRI shows that it's not, right? I mean, there's certain utility getting tests to show you what it isn't as you narrow down to what it is. But I don't like putting a lot of faith in that EMG because that's disappointing, right? Especially if the words you say are, it's a nerve, let's get a nerve test to see, oh wait, the nerve test is normal, therefore that implies that it's not a nerve issue. Not necessarily.
But back to tennis elbows. So like typical, I'll just like briefly go through the way we treat it, which is a little bit different than maybe some others might treat it or that I would have in the past. Therapy for sure. Sometimes those counterforce braces,
I do a wrist brace instead.
Wrist brace, like a cock-up wrist splint. Definitely therapy. Steroid injections, plus or minus. They're one of the few steroid injections that I tell people, like, this truly is a Band-Aid. Like, it's probably going to come back and get worse. Not great to repeatedly do. I'm a fan of PRP injections for this. People don't like them in the short term because they hurt, but they work pretty well, I think. Shockwave therapy, something that like we've semi-explored, but we don't have a shockwave unit here that we can like, I don't know. Do you ever refer people for shockwave treatment?
I have, only if it gets brought up in conversation, but we will do MLS laser treatment for that, more so than we'll do shockwave. But shockwave, again, for patients who have like their chiropractor friend who does that, great. You know, with lateral epicondylitis, I will tell patients if it's just inflammation, tendinopathic, partial tear, full tear, I find clinically they all present the same. Like, I don't think those that have severe pain equal full thickness tear. Sometimes it's just mild tendinitis.
I think, and I think honestly, and this is not like based on any research, tendinopathic tissue is probably more of a pain generator than a full thickness tear would be. So somebody with just purely tendinopathy and not necessarily any big tear, they probably have just as much, if not more pain than somebody with a full thickness tear who's been living with this more chronically.
I will do initial treatment of like what you said, the anti-inflammatories, the wrist splint, physical therapy. I will get to the point of MRI to see, quote, where they are on the spectrum of disease, but it doesn't necessarily matter because, I mean, yes, full thickness tearing, we are going to recommend surgery, which is very effective. I love rehabbing these people because it textbook follows what it needs to. But those that are mild, it's almost disappointing. They're like, well, it hurts so bad. Those are the ones I'll do an intra-articular injection as opposed to a tendon injection, but I will flip-flop back and forth.
Why the intra-articular? Just so that
just to not inject the tendon.
Yeah,
just to not inject the tendon. And then to kind of leave the playing field open for PRP if we need to. But PRP hurts there. It hurts.
People they don't like pass out when I do it.
Yeah, they do. It's that and the patellar tendon. It's like there's no place for it to go, but like right up in that, there's no burst of space, right? Like the shoulder. So they don't love that. But and then other like non-invasive procedures, 10X.
Yep, we do a lot of 10X.
We do some percutaneous debridement. I don't love our 10X procedure because I feel like eventually they go on to need the repair. I don't know that we've had a 10X that has really gone away and disappeared.
It's so funny because I feel like we'll go through this with everything, like time periods where 10X works great. Like people are doing great with just 10X alone. Fantastic. So we started doing more 10X and then all of a sudden a time frame people that just like aren't getting better from it. So just recently had a stint of people that were not like, the 10X, a little bit better, not great, PRP'd them afterwards. And sometimes that was very helpful to combine the two of them. So I think that is a good algorithm for partial tears and even just tendinopathic issues.
But I will tell you though,
and inject it with PRP.
We had, we met with a vendor who has a 10X type procedure, 10-jet. No, you guys do 10-jet. It was something else.
We do 10X now, but we did 10-jet in the past.
It was something else. It wasn't 10X. It wasn't 10-jet. It was something else. Yeah. But anyway, you micro debride and then you PRP. Like that's the secret sauce. But guess what? Insurance doesn't cover that. Yeah. So that's like that I find very frustrating when we get into tennis elbow territory because all those that are tendinopathic, mild this, moderate that, who don't want surgery, PRP is a great option and in the right setting works really well, but you're asking patients to spend more money, the time it takes to recover when you could have just done, it might not get better. Yeah. And you could have just done the surgery anyway.
Yeah. And that's like, I think that is a super frustrating thing with it too, because there's a ton of people that I do offer PRP to, and I want to try PRP for them, but like they just, and I get it. Yeah. And we do, I think, relatively inexpensive PRP compared to what I see as market values out there. So, but it's still expensive. So I get that people don't want to do it, but like, gosh, it's so frustrating that is not something that is or will be anytime soon insurance covered. But that's a topic for another day. So more lateral pathologies. Honestly, the rest of these that we kind of listed, I don't really, again, either I don't see it a ton or I miss it a ton. It's one of the two things. Lateral plica. I don't even think of plicas when I think elbow. Like that's a knee issue. So I'm like, that's not even on my radar.
No. And I think, I would inject an elbow if it looked okay and it was vague this, vague that, lateral elbow. I think you're safe doing the workup for lateral epicondylitis, you know?
Yeah. Lateral elbow pain, I think those are the two biggest things. Like, sure, you can have lateral pain from arthritis. You're going to see that on an x-ray more than likely. And I don't think it'll necessarily be as localized as lateral elbow pain. I think if somebody presents with lateral elbow pain, but you notice they have severe arthritis on their x-rays, but still presenting like tennis elbow, it probably just is tennis elbow. Yeah. Okay. Medial elbow pain. Ugh.
Well, hold on.
Wait, do you have another lateral?
Yeah, I have a little like snake in the grass. So lateral ulnar collateral ligament instability. We have had, and I can name them because when you treat them post-operatively, you have to splint/cast them in full pronation. Okay. So anyway, lateral ulnar collateral ligament instability, the ligament that stabilizes the radial head, when you twist something, push, pull, and you feel a pop, and there's like an instability pop in the elbow, you can see that. Like if you take the forearm surgically and you pronate, supinate, you can see the radial head almost dislocate. So that is a diagnosis of exclusion. That one is really, really hard to diagnose. You treat these ones for lateral epicondylitis, but they just have like a weird popping sensation, I guess. And then your physical exam essentially is the finding. So what you do is you repair the ligament. And then in order to not have them stress that, you have to splint them in full pronation. Just ridiculous because then your hand faces down for 4 weeks, but it works. The last couple we've done it on, it works.
So you repair it and then splint them for 4 weeks and then
just tighten it up. And then you really slowly have them work on supinating their hand. Okay. Yeah. So that one put it in your brain somewhere when
Yeah,
it's just not
yeah.
fitting the diagnosis. We've seen a couple lateral condylar repairs that they come back like, hey, I still have my same problem.
Yeah.
You know?
And
then
is it popping specifically?
it's
that
popping
they're-
with rotation.
Okay.
Yeah. It's popping with like,
Persistent pain still?
Yeah,
Or?
mhm.
Okay.
and when you go to, grip and lift something, it's like it gives out on you. Yeah.
And you're not like, this isn't something easy to catch on an MRI, I
No,
guess.
not at all.
Yeah.
Not at all. More physical exam findings. But
Yeah.
again, that's why when you work with someone experienced, they are bold enough to be like, no, I know this is what it is.
Yeah.
You know what I mean?
Yeah.
And I just think that's not even on like urgent care new grad radar because that's just not something that you learn about.
And it's also not something you're really going to change what you're doing
No.
in that specific practice setting. Will I? Yes.
Well, I'm telling you,
Yeah.
I mean, we've done over the past 10 years, probably maybe like 1 or 2 a year. It's that rare, but it is that not rare where we fix it.
Oh, I like that.
Yeah. All right.
All right.
Now we can
Medial
move on
elbow pain.
safely. Safely move on.
Safe to move on to golfer's elbow.
Yeah.
The less common twin of tennis elbow.
Yeah. And does this occur just in golfers, Hannah?
I think it really, have I seen it in a golfer? I don't know.
I definitely have, but is it always from golfers? No. And that's, you will spend some time speaking with the patient, but I don't golf.
Yeah.
You don't have to get this.
So basically the same pathology as tennis elbow. It's just on the medial side where the flexors insert. So I treat it the same way essentially, but it's a lot more rare. Like how often are you guys fixing?
Like 1 to every 3 laterals.
Yeah.
So I think definitely more rare. And when, just like with the radial tunnel, when you're looking at medial elbow pain, that ulnar nerve, especially in throwers, like that ulnar nerve is sometimes tricky in getting involved in the pathology.
Yeah, I think you need to go through your exam with this because I feel like medial elbow pain, you guys see a lot more like athletes.
Yeah, throwing
like specific throwing and overhead athletes. Yes, we treat cubital tunnel, but there's a lot more that goes into this for like your overhead throwing athletes and younger population than just golfer's elbow or cubital tunnel.
Yeah, and I think that a lot of urgent care providers, I've seen it, that ulnar nerve can be unstable too when they complain of like a popping or like a snapping sensation on the inside of the elbow. I mean, my head first, rule out medial condylitis.
Yeah.
Second, make sure that ulnar nerve is not subluxing because that can in full flexion sublux right out of that ulnar groove. And when we see that, sometimes that is by itself, but sometimes that is also in the setting of medial condylitis. I don't make a routine of it to do an ulnar nerve block because I feel like that one's so much easier to diagnose. It's so less vague than the radial tunnel.
Yeah.
Like my 2 fingers go numb sometimes. Okay. Well, that's your ulnar nerve.
And you can pick up on an EMG.
Yes.
A lot easier,
I wonder why that is. But yeah, you see it more in EMG, definitely.
Yeah. So, I mean, for exam wise for this, obviously golfer's elbow, like tenderness on the medial epicondyle, pain with resisted flexion, and then looking at cubital tunnel, positive Tennells, you can typically, if they have subluxation, you can feel that when you take them into full flexion extension, you can feel it popping. You want to definitely look for like true nerve weakness. So distally, that's going to be the intrinsic muscles of the hand. So I'll check typically always like their index finger abduction, right? Abduction, yeah. So that's important because if there's true weakness with cubital tunnel syndrome, that's definitely more of a surgical indication for us.
And when you miss that, that's a bad one to miss.
Yeah. Now for your athletes, you also have the ulnar collateral ligament stuff to worry about.
And that's a tough one because, well, let's back up. Baseball players are tough.
Baseball players are tough.
Baseball players' parents are tough.
Specifically that, yeah.
Yes. So there's, a whole other side conversation of those athletes that are pitching on immature elbows and those athletes that are doing too many pitch counts in a game or a week or whatever. And you can just beat down the UCL and it starts with partial tearing. And then it can progress to full thickness tearing. But I would say the majority of the UCLs we fix are just recalcitrant partial thickness tearing. that just will not get better with the shutdown, with the PRP, with physical therapy, with throwing analysis. And when we do UCL repair for a partial tear, we do the repair with internal brace. We will not do recons unless they have a full thickness tear, or unless it's like multiple partial tears in the whole ligament. It's garbage. But I like the UCL repair. They get back to throwing like at, competition level within 6 months, as long as they do everything well. Yeah. Then that's not the same for Tommy John UCL recons. Those are a year if they ever get back. So that's a tough, we don't jump there first. We will usually PRP them, but we will usually get them after they've had a year or 2 years of continued symptoms. And they usually have tried all the things. But the parent always wants them to get back to things. ASAP. Always. But more so, you will see the valgus extension overload syndrome, where they stress the elbow, and it's that constant valgus stress on the elbow that gives them that posterior elbow pain. So that, again, if you see a lot of, sports med elbows, that's something you should be able to see and diagnose. You'll see medial elbow pain on exam. If you put them in valgus stress, specifically ABER shoulder valgus stress, they don't like that. Pinching in the back of the elbow, MRI will show that you've got like a bone bruise pattern back there. So if you can shut them down at that phase, then generally you don't get to the UCL injury phase.
Shutting down is hard.
Oh, I know.
Like I feel like every time I have that conversation with a parent, they're like, okay, but
can they hit?
Can they hit? And in isolated instances, yes, I feel like I will allow them to still hit, because that's not putting the same stresses on it that throwing is. But it's always like there's some competition coming up. There's something showcase. I don't know. Like, we'll just rest it after this, but then we have this. So can we do this in between? And I don't know, this coach is traveling from wherever, and he's going to look at Johnny and Johnny.
Well, Johnny's the next best thing. Johnny's going to get a scholarship.
He's the best on his team. Okay, his coach is really going to be disappointed at you.
Also, Johnny's
if you take him out
14.
So Johnny's over here like crying. In the corner.
Throwing athletes and their parents and their medial elbow pain, that's so tough. It's so tough.
Psychologically traumatizing for me.
But I will tell you, if you have the immature, and again, I don't want to go into pediatric elbow because I hate that, but if you do have the skeletally immature patient who is a thrower with medial elbow pain, they can get a needle apophysitis injury, and that very quickly can turn into a nice little avulsion fracture. And guess what? Johnny shut down after that.
Johnny shut down. I actually saw that. I feel like I don't see a ton of baseball players, but I had one maybe 2 or 3 weeks ago, and I get contralateral x-rays because there's widening, but you don't know how much widening until you see
some
the
wide
other
is
side.
Good, some wide is abnormal.
And, I show them the x-rays. I'm like, this is your throwing arm. It is clearly wider than your other one, which it's going to be. Any throwing athlete that does as much as you do. But this is obviously a sign that your growth plate is very irritated. And you got to stop throwing for a period of time or you're going to pop that shit right off there.
And Johnny doesn't like that. Yeah.
So, shut those down real quick. Sometimes I cast them. Sometimes not.
I do. I will cast them. I had a pitcher who was also like a quarterback. So the throwing, like the repetitive throwing on that arm, I'm like, buddy, you got to shut it down. Especially because when you say the things to them, like you can't throw, and they're like, oh, I thought you just meant a baseball.
Like I thought if I was throwing
a football, I didn't think that's what you meant. You know, like I'll have those conversations and I'm like, how about we just cast you just to
protect you from yourself.
But medial elbow pain, golfer's elbow in the non-throwing athletes, pay attention to the ulnar nerve because sometimes it is. And you're throwing athletes, you got to understand UCL injury, what type of stress will injure the UCL, get them with the right therapist because again, run of the mill, returning them to throwing, you got to get someone who is experienced with return to throwing program. Flexor pronator strain, best case scenario. That's when it's not the UCL. But again, shut them down, throwing mechanics.
Specific baseball rehab person. Best friend. Sometimes not. Okay. Posterior elbow pain. Couple things going on here. We briefly mentioned VEO.
I would say easy. Posterior elbow pain, easy.
For the most part, I feel like it is. Now, how to manage some of these things, I'll go with the biggest two that we see. So brief triceps tears. I think we touched on this a couple of weeks ago. A distal triceps avulsion tear, fell on it, weakness with extension or can't actively extend their elbow, those need to be surgically fixed ASAP. So there's your treatment for that. Now you can also get like tendinopathic partial triceps tendon tears, and we'll PRP those and rehab them, and most of them do fine. Let's talk about olecranon bursitis though. I feel like that's super common and sometimes mismanaged and misexplained. I kind of hate olecranon bursitis.
I don't hate it. I hate it in that, like, I will see someone, and you can see someone that has that. And I think urgent care providers that will send that over to us, if they have a really decent olecranon spur, there will be a deformity there, but it's not always bursitis.
Right. And that's hard to explain to the patient. Like, I've had a couple of patients that are like, this side's bigger than this side. And I'm like, there's nothing for me to drain. Like, that is your bone.
That is your, that is your contour.
Yeah.
When it's bursitis and it's just, let's say, I don't know, it's the older guy that just does a lot of work. Even he works at his desk and just leans on his elbow all the time. Then you talk about draining it, right? Do you want me to aspirate it? If I aspirate it, do you or do you not do a steroid injection? I know Hannah's standpoint on this, because Hannah has seen if you do a steroid injection and the patient's diabetic or they're not, that goes downhill pretty quickly.
Yeah. I will not ever inject them with steroid.
Yeah.
Ever, ever, ever. I saw one person come back from having, I didn't inject it, but they came back from having a steroid injection like a month later, and they were like, oh, it's just like something's happening to it. And literally the nastiest shit I've ever seen in my life was just like
draining,
coming out of it.
Yeah.
And
I compare this to prepatellar bursitis.
Do you get infected prepatellar bursitis like that?
I will drain it, but I won't inject it.
Yeah.
Because they'll come back like super angry and infected.
Yeah. That is the biggest issue with olecranon bursitis. Okay. So somebody comes in, they have a giant golf ball sitting on the back of their elbow, palpable effusion. Like, it's pretty obvious. Google a picture of olecranon bursitis. Most people can't miss it. So there is aseptic and septic. And then there's also traumatic. So you can have just purely like normal yellow colored fluid that fills it. You can have an infectious olecranon bursitis, typically from like a puncture wound, or maybe they scraped their elbow and some bacteria got in, and then it's filled with nasty stuff, or you landed on your elbow and it's filled with blood.
Yeah.
So let's say they come in non-septic, atraumatic olecranon bursitis. They want it drained because their elbow looks weird, and maybe it's like painful or uncomfortable from pressure. You can drain them. You have to be super careful. I'm like, swab these with like 5 betadine sticks and alcohol. Super sterile technique for these because I've seen them get infected a lot. The issue comes when they recur. And they will sometimes. Like, I put a compression wrap on it, sometimes sling them or even splint them to try to prevent recurrence. But that bursal sac can fill right back up. So then the patient has a recurrent effusion. They go to another urgent care the next week, and they're like, hey, I got my elbow drained and it came back. And then this other urgent care drains it again. And then 4 weeks later, it came back again. They go to another urgent care and get it drained again. Now they're definitely infected.
Yeah, they're definitely infected.
Yeah.
It's one of those things that I would tell the patient, it's like a beaker cyst, right? If I aspirate this, there's a chance it may come back. And it may come back when you get to the parking lot.
Yeah.
That does not mean I'm going to drain it again.
Yeah.
Right? But I will wrap them, and I will tell them over time it should get smaller.
Yeah.
But if you've got, the guy or the female that's super happy, they just wanted to know what it was, and you tell them it wasn't cancer. Easy. Sometimes they can walk out and they're like, oh my God, thanks. I will coexist happily with this lump on my elbow.
Yeah. And I'm like, give it time. Like, it'll probably go down on its own. If it doesn't, it's bothering you, significantly a while from now, like, we can surgically excise the bursa. You may have a big bone spur on the back of your elbow. We can take off. People get fixated on like the bone spur is the association between the two, and they're like, oh, I have to have surgery for this because I just need the bone spur removed. And sure, if it's uncomfortable when you rest your arm, like, yeah, that's a reasonable thing to do. But just jumping straight to surgery for these, or even straight to repeated injections, as I hate more.
Have you ever done doxycycline sclerotherapy on these?
No, but one of the docs I used to work with does them for
prepatellar bursitis.
It was something Morale-Lavelle lesions.
Yeah, that. Yeah. So I've done doxycycline sclerotherapy on all those.
Yeah.
And when you do that, you're supposed to inject doxycycline into the aseptic, atraumatic elbow bursa, and then you pancake the patient. You
right.
literally
You like
have
make them turn on their side.
So it's 15 minutes. Let's say they're prone, 15 minutes on the left side, 15 minutes supine, 15 minutes on the right side. And then, it's an hour, right? They're in your exam room for an hour. And then after that time, you aspirate, and it's supposed to kind of deliquefy the bursa. I would say, I don't know, maybe 75% effective. Enough where I would do it
cool.
again.
Yeah, like that's a good thing to try.
Yeah.
What I would be curious, like, how does the doxycycline affect the triceps tendon, or like?
Well, I mean, I would think,
is there a concern there? I don't know.
I would think you'd be superficial enough, but I mean, at the time, doxycycline was on back order, and I couldn't order it. So like, I feel like there's always a reason.
Yeah, we don't
to not
do a ton
do
of
that.
those.
But I would say probably 75% effective. Recurrent atraumatic olecranon bursitis.
Yeah, because I was actually thinking of that like 4 or 5 years ago. We had a patient that had a cyst in his tendon sheath from like a recurrent trigger finger cyst, and it just kept coming back, like kept draining it. Huge problem. I think we like went in 2 or 3 times to remove this, and he just kept coming back.
It's super annoying.
Yeah. So I'm like, do we doxycycline this? But like, how does that affect the flexor tendon? Like, is his flexor tendon going to
scars
rupture?
It. Like the whole,
or like, will it scar down his tendon?
The sclerotherapy is it's supposed to scar the tissue. So if you think if it's just clear-cut bursa, clear-cut cyst, the cyst or the bursa walls will scar to each other.
Yeah.
So let's say in an attempt to get rid of the cyst, you now scar up the tendon.
Like, that's not an ideal. No, you're not worse off.
Yeah.
Okay.
But again, they don't teach that in school. Like,
no,
that's
they
something
don't.
like on the job. You're like, oh, that's a thing.
We're talking about it right now. We don't. Yeah. Let's end on anterior elbow pain. Something near and dear to our hearts.
Very near
to
and dear.
Our weeks.
Yeah, and there's not a lot of stuff that lives in the antecubital fossa. So like, it should be easy. It should. I think what is confusing sometimes is when you think it's a distal biceps injury or not injury, but it's really brachialis, you know?
I've
because
seen a couple of those,
everybody thinks that biceps is your main flexor of the elbow. It's not, right? I mean, that's, I've seen a lot of, radial head distal biceps bursitis, and in the ultrasound course that I've taken in the past, like, oh my God, yeah, you can inject that. Hello? Like, it's so deep.
Yeah.
First of all. Second of all, radial nerve is kind of right there, and all your vasculature is very much right there. I don't know that I've ever done that. I've ultrasounded it and seen, like, you know, like the textbook shows you, if you have them pronate supinate, you can see that bursa rotate. Yeah. But that's ballsy. Yeah. It's ballsy.
I did it once.
It's ballsy.
It was ballsy. And I was like, it's just, I mean, they said it helped a little bit afterwards. I don't know that was what was contributing to this person's issue as much as some other confounding things. But I used ultrasound and
have to.
I mean, I basically just, yes, I used ultrasound to localize it in, but more importantly than anything, it was more like, are you feeling any shooting nerve pain while I'm doing this? And making sure I'm not around that. And like, let me aspirate before I do it. And like that, those are the things that made me feel safer about it than the ultrasound alone. But so distal biceps ruptures, I think you're always safe if you're concerned at all. Just get an MRI.
Yeah. Stat MRI for distal biceps. And you'll see a defect most of the time if it's like an acute full thickness. But the tricky ones, like the tennis elbow, is the partials, like someone who's had pain for a long time, or someone that felt a pop, but there's no deformity, but all the tests are positive. So how do you educate those patients? I remember how we used to do it, because we send most of them to you guys now, but like when they have a partial tear, hey, we can go in and fix this, AKA detach what is there, which is probably bad tissue, debride it, and then repair it. And then now you're like a, post-op repair. Or if you leave it alone, if it fully pops, you call us immediately.
That's pretty much the same thing.
It's like a ticking time bomb.
It is. Yeah. And so either I think of these as just non-urgent surgical patients. Most of them, if they have had a chronic enough issue for a while that it's bothering them, they do want to fix it, but it just doesn't have to be at the same level of urgency unless they feel that last little pop that gives, and then it becomes a little bit more urgent. But it's basically just telling them like, hey, at some point it's probably going to give on you. We need to fix it. If it does, if you want us to just take care of it now because it's a more convenient time for you, just do it.
And then distal biceps, if you're worried about it, regular MRI. UCL, if you're worried about it, arthrogram. Yeah. That's a good definitive test, because if you send them for a normal MRI, and we have to send them back for an arthrogram. That's never a pleasant conversation.
Pronator syndrome, anterior elbow pain.
Yeah. Pronator syndrome.
That.
Yep. Back to distal biceps because I'm living this life right now. Yeah. Do you fix all of them?
You don't have to. I feel like we fix the vast majority of them. My conversation with people is typically like, hey, this isn't going to kill you, obviously, right? Most orthopedic things will not and are elective procedures, but you can very much live without your distal biceps being attached. You only have one tendon insertion there, so like you will not have function of it afterwards.
That will not be attached if it's not attached.
Yeah. So you will have some loss of function with it. Now, will that level of loss of function affect you? That varies person to person.
Yeah.
So like if you are not super active, an older patient, non-dominant arm, all these things, like you really don't have to get it fixed. I don't even know if I tore mine, which it's not super common in women.
That's another thing. Yeah. I had a urgent care provider come up to me the other day and she's like, oh, this lady, you can very clearly see it's her distal bicep. I'm like, it's not.
Yeah. Like I've never seen it. I've never seen it. I don't know why. Yeah. But if I were to be, and I'm sure I wouldn't be the first, but if I were to be the first woman to tear their distal bicep,
I fully support you.
Would I fix it? I don't know that I would personally need to if it were my non-dominant arm. Would I fix my dominant arm? Like, I don't know.
It depends how old you are.
If I was like now.
And you're still lifting, the answer is yes, you would.
Yeah, I guess. But like it's more that supination, repetitive motion than elbow flexion. Like, will you still be able to bend and straighten your arm without 100%. A biceps? Yeah, absolutely. Will I look like I have a beefier, more jacked bicep if I just left it alone? Also, yes. So like, could that be a reason to not fix it? Maybe. Yeah. Maybe I just want to like look like I'm super like Popeye.
You may enter that point in your life where that matters to you.
Yeah, this is aesthetically a better option for me.
Yeah.
What if somebody like went in and surgically had their distal bicep tendons cut just to have?
So I have had patients who have torn one and they literally cannot wait to tear the other one. So they look like similar.
They're like,
it's like proximal too. Yeah. When they tear their proximal one, they're like, oh man, I can't wait to tear this other one. So they look like equally jacked.
So this is something to keep in mind, though, when you're thinking about biceps tears, distal versus proximal. If you tear your proximal bicep tendon, obviously you would typically have more shoulder pain, more bruising around that area. It's painful maybe in the moment, but then it typically resolves. Think about like which direction it would retract based on what your level of concern. Typically, the patient is going to tell you, I felt something happen in my shoulder versus I felt it happen in my elbow. But if you're unclear because of that, if your distal biceps tendon retracts, the muscle is going to roll up more proximal. Yeah. If it happens the opposite way, it's going to roll more distally. It's going to go towards the point of attachment.
Sense. But I mean, we say it like that and you're like, oh my God, yeah, that's easy. It's not though. Sometimes you see it in person and you're like, what am I looking at? Yeah. But yeah, elbow, I mean, when we talk about it now, like I feel pretty good about it.
I think that the elbow doesn't need to be as complicated as we make it sometimes.
I think, missing the diagnosis is bad. I think if you think the only things that exist in the elbow are medial condylitis, lateral condylitis, lichen bursitis, and your triceps, you're missing all the other things.
So many other things.
So I think on the list of things you guys should look up, if you're like, wait, what? Radial head instability, the lateral ulnar collateral ligament, plica syndrome, capitellar OCD. My daughter had that. Very rare. And she ended up having to have surgery. Referred cervical pain presenting as lateral condylitis. Yeah. I see that a lot.
Yeah.
Especially in our shoulders that are stiff shoulders. When they're trying to get the range of motion back, they are limited by their lateral elbow pain, which is usually some manifestation of
some sort of mechanical
thing. It's like a mechanical overload thing.
Interesting.
Inflammatory arthritis. I will see that enough where they present with an effusion out of nowhere. So that's another
like
one.
A rheumatoid type thing. Yeah.
Running blood work on those patients. But yeah, I think we did a pretty good job.
I think so. This was very insightful for me and hopefully for you as well.
Yes.
All of you.
All right.
Until next time.
Bye. Thanks for tuning in to Joint Effort PAs. If you enjoyed this episode, be sure to subscribe, leave a review, and share it with a fellow PA or med-minded friend. You can also follow us on Instagram at Joint Effort PAs for updates and extra content. See you next time.